Okay, so it is the 10th leading cause of death overall in the nation. It is difficult to gather real-time data around suicides for a lot of different reasons, and we could spend forever talking about that. But I do think it's important when we talk about Tennessee data. In Tennessee, suicide is the second leading cause of death for individuals aged 10 to 34 years old. And if you take that for just a second and ponder it, you'll realize you probably know someone within that age demographic. And more people die by suicide than in motor vehicle accidents, than by homicides even, and HIV. Now, whenever we look at male to female number of suicides, we see that males have a higher rate of death by suicide than women, even though women attempt 3 times more often. And the reason for that is the choice of lethal means. And we'll get into that a little bit more further along in the presentation. I also invite you, if you have questions or comments, feel free to put those in the chat box and we'll get to those as soon as we can. So as we move forward, I do want to point out that in 2018, the counties with the highest rate of suicides in Tennessee were in some of our most rural areas. So whenever you look at this map, what we see is that, for example, Bledsoe County, which is in the southeastern part of the state, or in southeast Tennessee, they had a rate of 47.4. Lincoln County, all in the south central part of the state, had a rate of 44. Clay County, up in the upper Cumberland part of our state, had a rate of 38.8. Again, another rural county, Henry County in rural West Tennessee, had a rate of 37.1. Houston County, which is in the Mid-Cumberland region, had a rate of 36.3. We know that individuals living in rural areas died by suicide at a rate that was 1.5 times higher than those in metro areas. So to give you an idea of how we discern our counties and regions, this map again illustrates how we define our regions and which regions had the highest rate of suicide. By this map, you can see that it was the south central part of Tennessee. Now, when we look at all of the regions across the state, there's 2 things that I tend to look at whenever I'm looking at data. I tend to look at the count, the number of suicides in each region, and then also the rate of suicide in each region. You can see from this map, I've highlighted the 2 regions with the highest numbers of suicide, being East Tennessee and the Mid-Cumberland area. And whenever we look at the highest rate of suicide, we see that that is in the upper Cumberland and south central region of our state. And again, those are very rural areas compared to other regions in the state. So what's different about suicide in the rural areas? Well, there's quite a few things. Whenever we think about lethal means, we know that over 2/3 of all death by suicide in our state are occurring with a firearm. Okay, we know that lethal means, meaning firearms, are more accessible in rural communities. Many rural homes have numerous firearms. It's almost part of the culture if you live in a rural part of the state. We have a lot of agriculture, a lot of farming, those types of careers across our state. And because of that, many farmers, are obligated to really protect their livestock, protect their crops from predators. And so the way they do that is oftentimes with a firearm. So they have easy access to that type of lethal means. We know that rural suicide rates in the US increased 48% from 2000 to 2018, while the urban suicide rate rose by 34%. For females, rural suicide rates nearly doubled over 2000, over the 2000 to 2018 time period, from about 4.2 to 8. Okay. The rate of firearm suicides in rural areas across the state is twice the rate that it is in urban areas. We know that in rural areas of our state, there's fewer resources in place. It takes longer to even access the resources that are available. It takes a while to drive into town, right? I happen to live in a very rural part of our state, and for me, going to the grocery store is a half-day excursion. So we know that because of that, appointments equals more time, right? And it can almost be more of a hassle. The sense of community is another factor that I think is different in the rural areas, or can be different in the rural areas. And what I mean by that is everyone knows everyone. Small towns, family drama, for lack of a better word, becomes front page news in the newspaper, on social media the next day. So seeing a therapist in a small town can get around. Family business, like I said, is front page news in a rural area. Some of the other barriers that rural areas and communities face include things like a shortage of mental health workers, of therapists, of other professionals that would be able to help with mental health. There's also a lack of culturally competent care. Thinking about it in terms of therapists may not be as culturally competent in the world of a farmer or someone living in a rural community. We are working on that in terms of being able to provide more telehealth services. We, as in the state, not me. And thinking about the best ways to be able to get services in the rural communities. We know that, again, there's a lack of resources for the rural areas, and the mentality of, there's definitely a lot of stigma still in the rural areas about seeking treatment for mental health. And that's one of the things our organization works to combat, is that stigma. Joanne, do you have anything you'd like to add to this? I know that Joanne is also from a rural area in our state, and has great insight into this.
Well, thank you, ma'am. But no, I do want to point out a couple of things and sort of elaborate on them. I know you mentioned the telehealth. So I know with COVID-19, sort of that where do we reach out to, who do we reach out to, has become perhaps a little less normal. But one of those things that I often find myself saying these days, if there's one good thing that has come from COVID-19, is that acceptance across the board with the use of telehealth. So our mobile crisis system is very robust in the state of Tennessee. We're very, very lucky to have that to the extent that we do, but really getting that buy-in from our smaller communities. I'm going to pick on Murray County. I'll shout them out, man. I know that I grew up, born and raised, right? And knowing that they're not going to drive to Franklin, they're not going to drive to Nashville to perhaps get that help seeking, that those services that they might need, but knowing that they can sit in their house now and have those assessments done over their phone, go to the library and use their computer if they need to, use their Wi-Fi if they need to, and it's been a huge asset in terms of reaching folks. So hopefully that will continue even after, obviously, COVID is done, fingers crossed, sooner than later. I did also want to go back to the lethal means briefly and speak on that safe storage. It's, as someone, and I know Misty knows this, and lives this as well, as someone from a rural community, as she mentioned, there are several firearms in pretty much every house that I've ever been in. And knowing how to safely store those. TSPN, along with other resources throughout the state, are able to provide gun locks. And so many different resources that can be used, because we know we don't want to necessarily take those firearms away from folks, but educate on how safe storage is so helpful. If there's a 1, 2, 3 minute time frame that individual has that time to process, then they're less likely to attempt or die by suicide if there's even that little bit of time frame. Also, I like to correlate it with the giant bottles of Tylenol that we all have. Whether we go to Sam's, Costco, it doesn't matter. It's that same messaging. How do we safely store our lethal means across the board?
Absolutely. And to piggyback on what you're saying, whenever we go out and do a training, which we'll talk about in just a moment, we specifically address lethal means safety and storage. And so one of the things we tell people during a training is if you have a firearm in the home and you have someone that might be thinking about suicide, one of the best things you can do to help keep that person safe is store the ammunition separate than where you have the firearm, right? And think about it. If you have a person in crisis who has direct, uninterrupted access to a loaded firearm, just as Joanne was saying, their ability to, or their opportunity to second guess themselves is almost non-existent, because suicide can be very impulsive. And so we know that if you can put space and time in between a person in crisis and their lethal means, you have the ability to help save their life. And the reason for that is because the peak of a suicide crisis, the most acute moment in that suicidal crisis, can last for as short as just a few moments. So if you store the ammunition somewhere else in the home, think about it. The person in crisis maybe, hopefully, has to go to a gun lock and open, get the key for a gun lock or know the combination for a gun safe. Let's say they get past that and they retrieve the firearm, but now they realize there's no ammunition, so they have to physically walk a distance to retrieve the ammunition. And the amount of time it takes for that individual to walk from one component to the next can be enough time for that individual to take a couple breaths and think to themselves, what am I doing? I can't do this. It allows for that peak to subside, right? You start coming down on the backside of that, and that can be a life-saving move. Another suggestion.
I'm sorry to interrupt. I did want, before you went on to a new topic, I wanted to get a question in because some people maybe missed the very front. What age did you quote for the second leading cause of death for suicide? That was a question by Teresa. And then a clarifying question, is the rate determined by population?
Yes, great question. So Teresa, it's the ages 10 to 34 years old. Suicide is the second leading cause of death in Tennessee as of 2018 data from the Tennessee Department of Health. The rate of suicide is determined by population. It's the age-adjusted rate per 100,000 population. Really great questions. I'm a data nerd, so I love those. So the other thing I wanted to mention on gun safety is I think it's important too that we think of outside the box ways to help keep people safe. For a long time, the mental health community has said, ask for their gun, take their gun away from them. I, being a registered firearm owner, carry permit holder, all of that kind of thing, I know that there is a financial attachment to firearms because they're not cheap. And I also know that some firearms carry a sentimental attachment. And so asking someone for their firearm can feel very invasive. And one of the ways we're trying to think outside the box in helping someone stay safe is, rather than asking for their gun, ask for their ammunition. People don't have a sentimental attachment to their ammunition, nor do they have as much of a financial investment in their ammunition as they do their firearm. But we all know that one doesn't work without the other. So we'll move on. Joanne, do you have anything else you'd like to add before we move on? All right. So one of the things that we're doing in Tennessee, among several other initiatives and movements happening across the state, is offering free trainings. That's one of the backbone services that TSPN provides, is free suicide prevention, intervention, and even postvention trainings. All of our trainings are free. You can find a list of them at our website, tspn.org. There are quite a number of them that we are now able to provide virtually, or we are doing some in person as well. And some trainings, we're not doing a blended version, but it's either going to be virtual or we can do some in person, depending on obviously what's happening with COVID and things like that. So some of the trainings that we do provide, our most basic one is called QPR. It stands for Question, Persuade, and Refer. This training typically lasts about an hour. And what we do is we teach you the warning signs, the risk factors, how to ask someone that question, are you having thoughts of suicide, and how not to ask that question. We teach you how to persuade someone to stay alive and get help. And then also we teach you how to refer them to the appropriate resources that are available to them instantly. We also provide ACEs, which is Adverse Childhood Experiences. We talk about early childhood brain development and how early childhood trauma affects the brain as it continues to grow and develop, and how the more trauma that's experienced, the higher likelihood it is that someone may think about suicide later on in life. We also, the ACEs can be anywhere from about an hour all the way up to 3 hours, really. And we could even turn it into 8 hours, probably. It's a really great training. We also teach youth mental health first aid. This is an 8-hour course that we are happy to provide, again, at no cost. It does a really good job of demonstrating the typical adolescent development, and then when the afternoon focuses on when it may not be typical adolescent development and when there may be a mental health issue starting its onset, right? We also do free trainings in the Columbia Suicide Severity Rating Scale. This training is, again, about an hour. It's free, and we can do it virtually. The Columbia Suicide Severity Rating Scale is the first screening tool that's been developed that addresses suicidality specifically. Most of the other screening tools address depression and sadness and things that kind of beat around the bush around suicidality, quite frankly. The Columbia does a really good job of addressing suicide ideation, intent, and behaviors. So we highly recommend that one. It was developed by the Columbia Lighthouse Project and by Dr. Kelly Posner, who's a great friend and advocate for our organization as well. Joanne, anything you'd like to add here? Yep. Okay. So to give you an idea of how we're doing across the state, what I wanted to do is give you a quick visual of how many people we're reaching all across the state, not only in our metropolitan areas, but also in our more rural areas across the state. So I pulled information about the outreach, how many postventions we've done or reached in each county, how many people we've trained in each county, and then give you the grand total of how many individuals we have reached in that particular county. So this one is going to focus on the number of individuals trained in each county, and you can see Weakley County, we've reached several thousand individuals in that particular county, and you can see it moving descending accordingly by training. This next slide gives you the breakout of the counties that we have done a lot of outreach in, and we have reached, this one is organized by the highest number of outreach, so the individuals we've made outreach to. So in Davidson County, you can see that it's over 6 million. Now, I do want to clarify this and say that this was for 2018. This is not year-to-date data. And also, obviously, there's not 6 million people in Davidson County, but this number represents how many touches, so to speak, how many outreach individuals we had the potential to reach based on the events that we were doing. I wanted to show you information that we collect from the National Suicide Prevention Lifeline Center. We will talk more about this resource in the upcoming slides, but I wanted to show you that we're able to capture this data and break it down by county. So you can see that the darker shaded areas in this map had many more calls to the National Suicide Prevention Lifeline call center. And what I noticed when looking at this map is that for the majority of the counties that are highlighted or shaded that dark blue color, they're considered pretty rural areas, with the exception of Knox County and Shelby County, obviously. So we know that people in rural Tennessee are reaching out for help. They are making calls to the National Suicide Prevention Lifeline and seeking assistance or guidance for help for someone that they know is in crisis or having thoughts of suicide, or even for themselves. I know Joanne's department is also able to gather data from the statewide crisis hotline number, which is different than the National Suicide Prevention Lifeline. Joanne, would you like to add?
Would love to, yes, ma'am. So, and any of you familiar with state government know how stingy we can sometimes be with our data, but hope to be able to get this to Misty so she can do a comparison across all the beautiful resources we have, both statewide and nationwide. But we have seen within, actually after this time period, if you look from April to current day, with our statewide crisis line, and she's going to touch on this. We'll touch on this later as a beautiful resource that you all will use. But in terms of mobile crisis and people reaching out to that, we've seen a huge increase since what I call the time of COVID, right? It's always interesting to look, and Misty, I'm fixing to go down a rabbit hole, tell me to shut up if I need to, but it's always interesting to look at times of struggle, whether it be a pandemic, a war, those sorts of things, when our suicide numbers trend downward. And Misty and myself are privy to some lovely preliminary data that we can't share because it's not real yet. However, we're seeing that trend is going down in our suicide. But with that, and I think this map shows, and other information that she's going to show as well, is really people are reaching out more than they ever have, at least in recent years. And it's beautiful. It's a beautiful thing that we see in these times of crisis. People are utilizing these resources, and what's so important, as I mentioned with telehealth earlier on, in these rural areas. They're able to say, hey, there's this resource. Hey, I don't have to drive to Nashville. I don't have to drive to Knoxville or Memphis to get this. I can simply call and utilize these resources. So wanted to add that.
Yeah, absolutely. I wanted to point out on this map that places such as Haywood County, Monroe, Montgomery, Pope, Putnam, Rutherford, Sullivan, Washington, in addition to some of those more metropolitan areas such as Shelby, Davidson, Knox, had pretty high numbers into the National Suicide Prevention Lifeline. Again, during that time of January to March, we don't have the data right now past March, but we are working on that. So I also think it's important to look at the veteran calls to the National Suicide Prevention Lifeline. And I think it's important to note that this percentage is of the calls coming from that county, that, for example, this 90% in Haywood County, that represents the percentage of callers that were veterans. So what we see is that in these very rural communities, it's mostly veterans that are calling into the National Suicide Prevention Lifeline, which I think is fantastic, that this many individuals are aware of that resource and are utilizing this free service. So just wanted to point that out. I think it's interesting. Some of the things that we as an organization are doing and have done and will continue to do is look at suicide rates in the rural areas. We formed the Tennessee's Farmer Suicide Prevention Task Force. Now, this was a task force that was chaired by Assistant Commissioner Carol McDonald with the Tennessee Department of Agriculture, and we're very thankful to her for her leadership in this role. And we were able to get various entities to be part of this task force that came together to address suicide in the farming community specifically. From that, we were able to develop and create a brochure that addresses farmer suicide prevention specifically and get that out to as many individuals as we possibly could. And you can see the list of participants. And this is just a fragment of the organizations that were part of that. We have seen, I don't want to say a culture shift, but we're starting to get invited to places where we've never been invited before. Such one example is there's a weekly update that happens with the commissioner for the Tennessee Department of Agriculture, and it's the Ag Industry Partners Weekly Update. And now we're invited to be able to provide an update weekly on that particular call, which I think is really fantastic because we're able to reach a segment of our state that is needs our help, right? Needs information, needs resources, needs to understand that suicide prevention is possible. So what is the data telling us that we have? Well, it's telling us that when we do a training, if you look at this, the yellow zigzag kind of line gives you an idea of the number of trainings that we do in each month. And then the blue and, excuse me, orange colored lines represent the number of individuals, the number of conversations that go to the crisis text line, which is another resource that we're going to talk about momentarily. But what this shows us is that as we are out in the community doing trainings, reaching individuals, talking about suicide prevention, we see the number of individuals reaching out to the crisis text line, almost a direct correlation as we look at month to month, which is really fantastic. For me, being a data nerd, this kind of proves our effectiveness in our outreach efforts across the state. So whenever we think about the available resources in the community, I do want to share a couple things with you. First and foremost, the mental health parity law. So this is a really important one, and it's not well known. It's not even on my slides yet, but I do want to share it with you. So if you have health insurance, more than likely you have mental health insurance. If you were to take out your insurance benefit card and flip it over to the back, there's probably a number on there for mental health, behavioral health, substance use, or something along those lines that you can call and learn what your mental health benefits are that work just like your physical health insurance does. So that's not a well-known resource, and I try to make sure I tell everyone that as much as I can. We have made reference to the statewide crisis hotline number, and it's on your screen. The very first resource we want to share with you is the 855-274-7471. It's a really good time to call this number when someone may need immediate mobile crisis services. So in our state, we're really blessed to have an adult mobile crisis system and a youth mobile crisis system. And before I go any further, because this is Joanne's world, I'm going to let her kind of talk about that a little bit.
Yes, ma'am. So as you mentioned, I'm out of the Office of Crisis Services and Suicide Prevention. So I'm the suicide prevention side. All the other folks on my team are on the crisis services side. So I definitely really encourage you all to get on this website, tn.gov/crisis line, because there are so many different options and services that are provided, and I think a lot of community members aren't aware of that they exist. But in terms of mobile crisis, as Misty mentioned, we have 13 different providers across the state. So every square inch is covered. And you can call this line. They utilize geo mapping, whole 9 yards, things I don't actually understand, to make sure that people are routed to the people that they need to be. Once again, picking on Murray County, if I'm calling from my 931 number and I happen to be at my mama's house, then I'm going to be answered by Centerstone, right? And they're going to be able to talk with me, provide an assessment, and see what next steps I need or the person that I'm working with needs. As I mentioned, the telehealth is a huge asset. There's no more having to meet at the emergency rooms, physicians' offices to have this happen. You can sit in the comfort of your home and be able to help someone who might be in crisis and might be thinking about suicide. But once they do that assessment, of course, they utilize the Columbia Suicide Severity Rating Scale, that training Misty mentioned. Give that a good Google too. It's something that everyone can provide, but of course there is that clinician level assessment that individuals in mobile crisis utilize. And then they immediately get them set up into what is best for them, whether it be all the way up to inpatient services, which is of course not something we automatically go to. We want to be able to utilize those other services, those less restrictive ones. So whether it's a crisis stabilization unit, a walk-in center, appointments with their region's counselors, and they'll make that happen. Those things will happen before you hang up with a mobile crisis provider. So a huge resource, 24/7, 365, and definitely something that I hope all of you will put that in your phone. Put all the numbers in your cell phone. They're useful, and it never hurts to have them.
Absolutely. The next resource we've talked about briefly is the National Suicide Prevention Lifeline. It is available 24 hours a day, 7 days a week, just as the statewide crisis line is. It's a good time to use this resource when you have questions about someone that might be in crisis, or you're having thoughts of suicide maybe, and you just need someone to talk to. This is a confidential line. You are connected to a trained crisis counselor who can really help de-escalate the situation or help you de-escalate the situation if you're concerned about a friend or a loved one. We have all types of information around the National Suicide Prevention Lifeline, as well as the statewide crisis line and the crisis text line, whether it's pins or bracelets or other swag items, tons of brochures. The last resource that I want to share with you that is really statewide, that doesn't matter where you sit in the state, is the crisis text line. So you may see across the state, across the various organizations, different entities telling you to text various keywords to various numbers. I see it all the time. For us, we have a partnership with the Crisis Text Line. It's a separate organization, so you're not texting anyone at the Tennessee Suicide Prevention Network, and you're probably not texting anyone at the statewide crisis hotline number either. The Crisis Text Line is its own entity, but like I said, we have a partnership with them. What that means is when someone texts the letters TN, so they actually type those letters in the message of the body, and they send that to the number 741-741, they are connected immediately to a trained crisis counselor, but via text. So this is a really great resource, particularly for our youth who don't know that a phone operates like this, or it used to operate like this, and they think it just operates like this, right? Or if someone doesn't have the emotional strength to have a conversation with someone verbally, they can do it textually. And we've seen a lot of great use out of this hotline. Now, the benefits, and I'm going to do a shameless plug here, but the benefits of using the keyword TN rather than another keyword that you may see distributed across the state is because of our partnership, we have access, direct access to a ton of information that allows us to really data mine and be able to extrapolate who we need to target based on the information we collect from this data. So for example, we see the age, we see the gender, we don't see names, but what we do see, which I find vitally important is the reason why this person is texting in. Is it relationship? Is it COVID? Is it abuse? Is it suicide? What are the top 10 issues that we see texters utilizing the service for? One of the trends that we've recently identified is relationships. Imagine that. We're in a time of COVID where relationships are strained for various reasons, including being home with family or not allowed to go out. What am I thinking of? What's the word, Joanne? Quarantined. People are quarantined. Thank you for that. And so that can put a strain on a relationship. Also, let's say you have a loved one that's in the hospital or in a nursing care facility, and you're not able to have that relationship with them in the same way that you once had it before. So we're able to target our prevention efforts based on the information we can gather when someone uses the keyword TN. There are a lot of other keywords out there, but from the ones that I've looked into and investigated, they don't have the same partnership. They don't have the same access to the level of data. So I encourage you, use TN when you use the crisis text line so that we can get a better picture of who is using the service across our state, which will thereby allow us to target our prevention efforts even more. Another example I use is we know that more women than men use the crisis text line. That's great. What that tells me is we need to develop effective marketing strategies to the men in the state and to be able to understand why don't they use it? Why is it not appealing to them? And develop appropriate materials to get in front of these men so that they feel comfortable using this as a resource. So it's a great resource, again, when you need someone to listen to, someone to talk to, someone to help de-escalate the situation, whether it's you in that situation or whether it's someone you care about and love and want to be able to help. So this is the end. We were going to have a third person with us today, and unfortunately she fell ill last minute. So I think we're going to have a few extra minutes if there's additional questions or comments that anyone has. Joanne, is there anything else you would like to say?
No, I just look forward to the questions. I know I'm happy to, you've got Misty's email there, and I'm definitely also happy to be reached out to as well. And I can put that in the chat perhaps if I can figure it out.
Well, this was great, both of you. As a clinical social worker, as somebody who works with a lot of rural providers, this is really helpful information. To get us started on the questions, I had a couple that I'll throw out, and then we'll see if folks get a little braver and put their questions on the chat. First question would be, do you have any specific information about college age folks and their responsiveness or lack of responsiveness? Any kind of data would be great.
Joanne and I are smiling only because our brains are pinging off of each other right now, because we at the Tennessee Suicide Prevention Network actually had a Tennessee Higher Education Suicide Prevention Task Force, and I will simply introduce it and allow Joanne to elaborate.
Happy to. So there was actually legislation passed almost 2 years ago now. Feels like yesterday, but it requires all institutions of higher education to have a prevention, intervention, and postvention plan in place. That's your 2 years, your 4 years, your privates, your publics, doesn't matter. So with that, we've actually seen increased engagement, of course, not only with the trainings that TSPN offers, but really in that continued outreach and that continued engagement towards that population. It's always been a difficult one to sort of grasp, especially depending on the kind of setting that they're in. If they're a 2-year at a community college, then they're in and out and they're not paying any attention, and they're, especially now, I mean, half of them aren't even in the schools. So working with different institutions, we actually have a program through our department to help collaborate with them and help oversee, that work specifically with institutions of higher education to help to create that plan, help them come up with a language to embed that within their syllabi, right? It's a simple thing and it's free. Every syllabus can simply have, here's the statewide crisis line, here's the National Suicide Prevention Lifeline, here is the crisis text line, go forth. Getting that on website. So huge strides have been made in the past couple of years within that demographic and continue to be made.
We have the information posted on our website as well. If you go to tspn.org and look for the Tennessee Higher Education Suicide Prevention Network, it might be called THESPN, THESPN for short. But all of the protocols, the sample protocols, all of the incredible work that was accomplished by this task force is posted on our website.
Gosh, I love hearing that. I also teach a community college class, so that's, again, near and dear to my heart. In the recent years, prior to COVID, I had heard several presentations about the rate of suicide increasing, or at least the rate of suicide gesturing and ideation and hospitalizations. Is that still happening? Are we still seeing an increase?
So what we're seeing happening post-COVID, right? The beginning of the year, January through March, we actually saw pretty level suicide rates compared to 2019 and 2018. Whenever COVID really hit hard in our state and in our nation, we see a decrease in the number of suicides for about March, April-ish, May-ish. And what we see past that is, so it's kind of going in waves. But I can say that very early preliminary data looks like it might be that we actually lose less people to suicide in 2020 than we have in previous years, which is hopeful. And we could speculate all day as to why that might be. Some of the reasons I would like to think is that people are home more, so there's less access to lethal means. There's more eyes on an individual. Excuse me, maybe there's more check-ins with that individual. Now, conversely to that, we are seeing more and more people reach out for help to the National Suicide Prevention Lifeline, to the crisis text line, to the statewide crisis hotline, which is also very encouraging. So I hope that answers your question.
Yeah, that was great. I really appreciate that. And it's good to hear. Good.
Misty, yes, we had a question, and you touched on this quite a bit. And in the chat box, I pointed people towards the farmers handout. But we've got a question from Bill about have there been many instances of suicide among Tennessee's farmers? And so I don't know if what time frame he's talking about there. I know you talked about it some, but do you want to maybe add to that?
I would, yeah. I think that's a really great question. The data that we have from the Department of Health does not break it out by occupation. However, we do recognize that farmers are at an increased risk of suicide for several different reasons. One, if they're raising crops, you're at Mother Nature's mercy. No rain this year or a lot of rain this year can completely wipe out a farmer's crop. We also know that farmers have access to highly lethal chemicals that they use to spray on crops, or vaccinations or medicines for the animals that they are raising, their livestock. We do know that farmer suicide prevention is something that we are taking very seriously. We've developed wallet cards, but unfortunately we don't have specific numbers on the number of farmer suicides in Tennessee.
And to piggyback on that, a lot of kind of the drive for this, it actually came out of data that Kentucky was able to collect. We're here in Tennessee, we're actually on the way, very, very close to being a partner within the National Violent Death Reporting System. And what that does, kind of as it sounds, is that violent death reporting system really breaks it down. occupation, have they been to a clinician with a certain time frame, whole 9 yards. So in the next couple of years, we'll be able to pinpoint that specifically for Tennessee. But Kentucky, and though I'm 100% Tennessee, and apparently we have a lot of correlations and connections with Kentucky, right? Even though their grass is blue, which confuses me. That we're able to sort of see that they were having a specific issue, and it makes sense that we would have that similar issue, especially with the robust dairy farmers that we have here in Tennessee, and the impact that they've had for several years now with losing those farms. So.
Along the same lines, and this might be something even Elizabeth can weigh in on too. One of our board members is executive director of the Men's Health Network, and I just happened to get to sit in on a call with them this past week, and they were just talking about the difficulty in getting resources and really targeting men for things. And I think it came up even in this conversation a little bit here as far as tailoring the messages. So maybe just elaborate more on just men's health in general, and how we communicate with men, maybe resources that are available. And then I'm curious too, the telehealth link, is that going to make it more accessible or not? I don't know. So I'm going to turn that over to you all.
Well, I'll start by saying if we figure out the key to communicating with men, we've got a jackpot $1 million idea. I mean, I'm just teasing everyone, just teasing. Just
teasing, but everybody's agreed.
Yeah. So yeah, I mean, in our profession, you know, we do get to work with a lot of men and use that insight in helping us develop and create materials that we feel would reach men more effectively. I think there's a ton of cultural barriers to men, particularly living in the rural areas, reaching out for help and assistance, whether it's mental health or physical health or anything else. I think there are times when, let's say, I'll use my personal experience. I'm not speaking for anyone else, but in my experience, the farmers that I know, that I'm related to, that I love and care for every day, are quick to go to a doctor if they have sustained an injury that prevents them from working on the farm, right? Mental health is not something that they see prevents them from working on the farm. And so it can be challenging for a farmer, a man, to want to give up that time from his crop or his livestock to go address his mental health needs. Culturally, it's just not something we have seen a lot being, you know, everyone goes and gets assistance when they need it. That doesn't happen.
So I'm going to jump in for just a minute because I do provide telehealth, and I also work in a very rural medical clinic in McKenzie, and the telehealth services are a really good bridge. It allows folks to come to the doctor and perhaps also see a mental health provider in the same visit. It allows them to bring their kids into the pediatrician and maybe also see a mental health provider. So the barrier at times of having to make a separate appointment or a separate visit, take separate time out of work, whatever, it starts to really be convenient. And convenience and offering more portals, I think, are a really good way to start to make it easier for men.
100%. And JC, thank you for posting this in the chat. I want you all to click on that link on there for me. I've got a little bit of commercial for you. But we see a lot, and full disclosure, and this is probably stupid of me to share this month especially, but men, especially in that middle-aged group, are really my passion, right? I'll share a little bit about my story, why the cat hair I do what I do, but I lost my father to suicide December 1st, 2011. So I'm coming up on the 9-year anniversary of his death. He was 45 years old. He worked in water construction, in a rural county, in a rural area, and kind of took that rurality, is that a word, as a okay, sweet, Misty says it is, as that badge of honor. I am man. I work outside. My muddy boots are kind of my stamp of what needs to, this is who I am, right? And so we're finding, and we're working really hard out of my department. It's kind of my baby, really, is with the Be the One campaign. Now that link that JC shared, thank you again, is a huge link, and one that I'm hoping we can continue to share, especially in our rural areas, because where do men always do? They go to work, right? So working in workplaces for workplace suicide prevention is really hopeful to be able to reach these folks in a way that ideally decreases stigma across the board, decreases that stigma around help-seeking behavior, whole 9 yards. But the Be the One campaign really focuses in the workforce, and something that I would love to be able to talk to you all about. Email me, and I'm happy to give you a more thorough commercial.
Well, and we may have just a few more questions, and actually there is one in the chat I want to get to. But also, if people have to jump off for whatever reason, please fill out the evaluation. That helps all of the speakers on this for their grant reporting. It helps us for event planning, and the link for that is in the chat box. It'll also be on the event page. Joanne, I'm also going to put this in some of our other resources. We just updated our website and are kind of developing some resource banks, so we'll make sure that that gets included also. But a question here from Diana, and she thanks you all for a very rich discussion, and says that the rate of veterans in Haywood County in West Tennessee calling the National Suicide Prevention Hotline is alarming, and she's asking if there's any sort of program developed to address that issue specifically, and she's asking if it's an anomaly compared to other areas.
Great question. So let me clarify, and I apologize if I didn't make this clear, but that percentage that I showed you of the veterans who were calling in was from the total number of callers who were calling in. So if a county had 90% of veteran callers, I mean, they could have had, 20 calls total to the National Suicide Prevention Lifeline, but 19 of them happen to be veterans. So that's where that percentage comes from. And don't quote me on that math off the top of my head, because I know it's not right, but to give you an idea. And so, yes, there are a lot of initiatives happening right now. This morning, actually, I had a meeting, Joanne and I both did. We are on the Governor's Challenge to prevent suicides among service members, veterans, and their families. This is a task force that has been created from a national level and actually kind of filtered down. So Tennessee's Governor Lee, accepted the challenge to look at how can we reduce those suicides among that population. I also sit on the Clarksville-Montgomery County task force, which is a mayor's challenge to do the exact same thing. In addition to those two task forces that we're a part of, we also have a statewide Veterans Suicide Prevention Task Force. This task force came together over the last number of years and developed a toolkit that will be published hopefully very soon, that gives community members, stakeholders, organizations kind of that jumping off point of recommendations on what they can do to reduce the number of veteran suicides within their catchment area. In addition to that, we are part of other teams looking at veteran suicide prevention. We know that the VA just hired community engagement specialists all across the state. They're still hiring those, excuse me, and their main objective is to embed themselves within the communities that they serve looking at how to reduce the number of veteran suicides within that community. So we know that I believe 5 or 6 have been hired so far, and they're still looking to hire 4 to 5 more individuals all across the state. So we'll be getting those guys up to speed very soon. We also know that the President's Roadmap for Suicide Prevention, Prevents, is gaining more and more traction, not only in our state, but across the country as well.
Great.
So a lot of things happening.
Can I ask one more question? I know
Yeah.
we're out of time.
Nope, keep
Because
asking.
I work with IHC and we work with rural practices across the state. Is it possible for you guys to come out and do some of the trainings that you had listed?
Absolutely. We would be happy
Wonderful.
to.
Okay,
Mhm.
that's great. We'll be in touch.
And just so you know, everybody, the Be the One is also free and virtual, because I've been stuck in my room for a very long time. So, but happy to do that anywhere and everywhere.
Great, great.
Well, we certainly know that virtual is not everybody's favorite format, although I will say I have some very comfy fuzzy socks on today that I wouldn't have got to wear in person. We really appreciate everyone for joining us, and we're doing the best we can. I think that's the theme of our conference, right? That rural resilience. And so we just figure things out and do the best with what we have. As a reminder, on our event page, there's a conference lounge section. If you want to add pictures of yourself in your Rural Resilient t-shirt, or send messages to others who maybe missed the session and encourage them to watch the playback, or anything you want to share, there's a chat box there. Also, Integrative Health Centers, which is one of our gold sponsors, they have got a space there. There's some bonus activities. So we've got a yoga video up. The Rural Health Day coloring book is in there. So again, it's not in person, but we've tried to like put some things here and there to give you a little bit of extra and engagement. This will be on the recording of this will be on our event page, along with the resources that we have shared today. Let's see what else. Oh yeah, t-shirts. We'll have to get you, Misty and Joanne, we'll get you a Rural Resilient t-shirt. They're very nice. They're very nice. Let's see, other than that, tomorrow we've got some education speakers. Hopefully Lynn feels better. A couple days from now, she's giving a talk communicating with people who have dementia, Alzheimer's. And then later next week, we've got several sessions either related to opioids, telehealth, broadband. Of course, if we're talking telehealth services and virtual trainings, I think we've all run into some access and digital equity issues there. So we'll be talking about that, as well as some prevention screening strategies. So lots planned. We know that not everybody is going to make it to everything, but hope that you find the sessions valuable and you're able to watch the replays. And then last reminder is, if you need CEUs, there are instructions for CEUs under the information desk on our event page. And so at the end, when you have gone to all of your sessions, there is a form that is required by the people we submit to. And we just will verify your attendance via the GoToWebinar feedback, and submit for that later. So nursing, social worker, and general CEUs. So I think that is all, ladies. Thank you very, very much. Really appreciate your time today, and even going in a little bit of overtime for us.
Thanks, Tracy. We appreciate all your.
Thank you, everyone.
All
right. We'll see everybody later. Bye.
Bye-bye.
Bye.